Good afternoon. Welcome to Charting the Course, Waldenstrom Case Studies. My name is Meg Mangan. How many of you have gotten a second opinion from a Waldenstrom expert? Quite a few. As you probably know, most oncologists aren't familiar with Waldenstroms because it's so rare. That's why the IWMF recommends, whenever possible, getting a second opinion before initiating treatment. And when complex situations develop, patients are also encouraged to consult a Waldenstrom expert. Today, we've assembled a distinguished group of oncologists who are very familiar with the challenges that WM sometimes presents. To help us learn more about our rare cancer, I'm going to present them with a few patients who are seeking a second opinion and ask for their recommendations. If time permits, there will be an opportunity for questions from the audience, so keep that in mind. Our distinguished panelists are Dr. Rachid Baz, Dr. Jorge Castillo, Dr. Shirley, Dr. Jeffrey Matous, and Dr. Shayna Sarosiek. Our first case is Phoebe, who was diagnosed with WM and hemolytic anemia in 1997 at the age of 46. A splenectomy resolved the anemia. Then a few years later, hemolytic anemia returned and resolved with rituximab. Hemolytic anemia appears to have returned, as evidenced by her hemoglobin of 7.5, a positive Coombs test, and 0 haptoglobin. Now her IgM is 150, and bone marrow shows no evidence of LPL cells or CD20 markers. She's very fatigued, but able to work as a receptionist. Her local oncologist said a BTK inhibitor won't work because she's MYD wild type, and suggests CAR T cell therapy. She wonders if that's her best option. Who would like to go first? Dr. Castillo, I'm going to pick on you because you're right there at the end.
I always go last. Well, I'm happy to kind of look at this case. Obviously, this case is a complex case, and most of us in the audience will feel that there's some information there that might be missing, and it's a little unclear, right? So let me just walk through the whole process, just some minor concepts about hemolytic anemia. It's a concept in which the red cells are getting destroyed in the patient's blood system, and it can cause symptoms of anemia, which is a little bit different than the regular anemia that most patients with Waldenstrom's have, in which the bone marrow is being overcrowded by the malignant cells, and therefore the anemia is a production problem. This is a destruction problem, so it's just a little bit of a difference. It says a positive Coombs test. There are actually two different types of positive Coombs tests. We have what we call the warm antibodies and the cold antibodies. The warm are IgG-driven. The cold are IgM-driven. In Waldenstrom, we actually see both. We can see the IgG type, and we can also see the IgM type. So warm or cold. That is not specifically specified here. And they're managed just a little bit different, right? The warm antibodies can be managed with high-dose steroids, and there's some success with that. The cold, or the complement Coombs test, or the IgM positive Coombs test, that typically does not respond well to steroids, and that might be related to an underlying lymphoma, like Waldenstrom's, and we need to treat the Waldenstrom's to make that better. The IgM is 150, so I assume that's normal. With a bone marrow biopsy, that shows no evidence of disease. But it doesn't say that there's an SPEP, right? SPEP actually detects microscopic evidence of abnormal IgM, so it's not clear to me here if it's a persistent SPEP or not. Patient is fatigued, and I understand that with a hemoglobin of 7.5, most of us will be fatigued with that at that level. So I think the anemia is causing that problem. Now, the issue that I have with this case specifically is I do not know which type of Coombs test the patient has. And number two is how related to the malignancy, to the underlying Waldenstrom's, this process is at this moment. From my perspective, I treat Waldenstrom's when two criteria are met. Number one, the patient has symptoms enough to make them feel sick, like in this case. But the second is that we need to have a high degree of confidence that whatever is happening is actually secondary to the Waldenstroms to treat. So I'm going to stop right there and see what the rest of the group has to say.
So maybe I can jump in. I agree. You need to know what sort of autoimmune hemolytic anemia it is. If it's a cold hemolysis, cold agglutinin syndrome, steroids wouldn't work. So that's one thing to bear in mind. So we need more diagnostic certainty. Secondly, it's a massive jump to go to a BTK inhibitor in the first place, or even, I mean, let alone CAR T. That's like really way, that's like beyond the sort of stratosphere, I think. She had hemolytic anemia in 97 and had rituximab at some point, which worked. I think I would go back to a trial of rituximab if she is still hemolyzing. I'm assuming for the moment this is a cold hemolysis. You can give 4 cycles weekly for 4 weeks. It takes time to kick in. She may need transfusions in the meantime. She should be on folic acid. She should keep warm. The fact that the bone marrow is negative means that the retux from before may have helped clear the marrow, and it's still sort of clear, but you can get this autoimmune process separate from actual detectable marrow disease. So I would actually go to a retrial of Ritux. It's straightforward, it's simple, relatively safe. If that doesn't work, then, or if her hemolysis is very brisk, and if it's cold, then there are complement inhibitors, such as atilimumab, which are available and FDA approved. So it all depends on the rate of change, how she's doing, and a bit more detail about the Coombs.
I think if I can, it's important that this patient doesn't have Waldenstrom's. And so Waldenstrom's doctors, we often see patients who have what we call IgM-related disorders. And this is probably cold agglutinin disease or cold agglutinin syndrome, but these patients get referred to us. They're quite rare, fortunately, and challenging to treat. But I have these patients referred to me with the diagnosis of WM, and I really question whether or not the patient actually has a diagnosis of WM.
So an additional comment is, so it says here the BTK inhibitor will not work because the patient has MYD88 wild-type disease. If there's no disease in the marrow, the MYD88 testing will likely be negative, right? And we do not know if it's truly negative disease or it's just the fact that there's not enough cells to detect the mutation. So that MYD88 wild-type could potentially be a false negative result. So, we need to be mindful of that at this time. And I agree, I think CAR T cells at this moment are not part of the standard treatment for patients with Waldenstrom. So that's, so we do have some evidence, some minor evidence published, but there's no approval by the FDA or the NCCN or the EMA or any of those. So I would not expect CAR T cell to be a treatment option to be discussed in a patient with Waldenstrom's at this time.
George is a 74-year-old veteran diagnosed with Waldenstrom's in 2018 and was last seen in the clinic 6 months ago. He now complains of hives on his extremities and trunk, increased fatigue, and joint pain. He's lost approximately 10 pounds without explanation. Upon questioning, he admits to drenching night sweats, which have progressively worsened, and intermittent low-grade fevers. His labs reveal an increase in IgM from 2,500 to 3,000, mild anemia, and low neutrophils. His local oncologist has requested a case consultation to confirm diagnosis and a treatment plan. Dr. Sarosiek.
Okay. So I would probably start with a couple of things that I would consider in this patient. So it seems like likely a lot of these symptoms could be related to the Waldenstrom's, and so it may just be Waldenstrom's progression. But the other things I would be thinking of in this case in the back of my mind to consider would be if there's any chance that this patient has a transformation to a large cell lymphoma. With the weight loss and the night sweats and fevers, that's something that we should consider. And so I would make sure to evaluate for that. The other thing, these are just things in the back of my mind in regards to joint pain or symptoms similar to that. A lot of patients with Waldenstrom's can have rheumatologic disorders as well. So I often work hand in hand with rheumatologists in case the patient has other autoimmune disorders. So those are just things I'm thinking in the back of my mind. But in the forefront, there is a syndrome called Schnitzler's syndrome, which is rare. I didn't include it in my talk yesterday. Maybe I should have. But it's a condition where patients can have significant inflammation, joint pain, fevers, rashes. And this sounds like the patient might have Schnitzler syndrome as a part of his Waldenstrom's progression. In that case, typically I would treat with standard Waldenstrom's therapies that we would use in other patients, and usually the symptoms from Schnitzler syndrome will resolve in those cases.
I would say these, like, usually, often in Schnitzler's, the neutrophils are raised, right? So, I mean, I also think Schnitzler's is a possibility. I think we have to think about, because he's got hives, so that is a skin manifestation. The weight loss could happen as well, I guess. It's quite dramatic. So maybe a PET CT would be good. The thing about Schnitzler as well is there is very specific therapy, right? Anakinra. So it's a specific interleukin-1 inhibitor. So it is an important diagnosis to make, but it's sort of based on clinical parameters. There's no like Schnitzler test, but I think that came to my mind as well.
Can I ask my colleagues, would you treat for Schnitzler's or treat for WM? Shayna kind of weighed in on treatment for WM.
I have, in the cases I've had, just treat the WM and the symptoms improve.
Yeah, so if the symptoms that we're treating are purely the rash and the joint pain and the fevers, then I would say that's Schnitzler's. But if the patient has anemia or other manifestations of disease that are more consistent with systemic Waldenstrom's, right, then at that time I think it deserves systemic therapy, right? So I think we'll try to understand really well what is the main driver of what we're trying to do. So in this case, for example, I will do another bone marrow biopsy, or mutation analysis, a PET CT scan, right? And really understand very well what is the indication to treat so we can select exactly the best treatment option.
So we want to see how big the WM is, the size of the disease. I think if it's sort of not in itself seeming to be very aggressive, we would sometimes give IL-1 inhibitors. But if it doesn't respond to that, then we probably would tackle the WM as well, or usually in parallel. So,
yeah, in most cases that I've seen so far, I mean, just with the hand, with the fingers in my hand, very rare, this Schnitzler condition. So we typically treat with the IL-1 inhibitor first, and only when the disease progresses to the point that it doesn't respond to that, then we treat the Waldenstrom. So that's the usual approach that we follow.
Agreed. I was assuming, though, that maybe the anemia, low neutrophils, increased IgM, weight loss were...
Yeah, no, I think that's more likely disease, and that's the point.
Me too, actually.
More likely we'll need systemic therapy.
Yeah, but a lot would depend on what the marrow shows, what the PET shows, and I think you really stage the patient and you get an idea where he's at from a disease burden. And if there's a lot, then obviously it's more the WM treatment.
James is 56 years old, working full-time in an office and complains of fatigue. He was diagnosed with WM a year ago, and he also suffers from rheumatoid arthritis. His hemoglobin is 11.2, and tests for occult bleeding were negative. A lab workup for the source of anemia found decreased iron, ferritin, and transferrin saturation. His total iron binding capacity and soluble transferrin receptor were increased. His local oncologist is suggesting oral iron supplementation, and he's seeking a second opinion to find out if that's the best treatment option. Dr. Baz?
Yeah, I think, this patient has iron deficiency anemia, and I think obviously in my bias would be to use IV iron, and it's, very effective, very safe at replacing iron. A little bit quicker. Sometimes oral replacement can be, challenging in patients with WM in terms of, one, tolerability, and two, raising the, iron stores. So my advice may be more, I would, do the IV iron instead of the oral, but I think it's not wrong to try oral iron first, but usually we're gonna run into issue with constipation and, in terms of efficacy of, raising the iron. So IV is what I would advise.
I would say that's reasonable. I think if a patient's minimally or not symptomatic, they could potentially try oral iron initially if they wanted, but IV iron I use frequently and is very effective. But I also, any patient like this, I always recommend that they have a workup for other causes of iron deficiency, because certainly we can see it with Waldenstrom's, but we don't want to miss that there's another condition that's present. So I would say, along with, in conjunction with the iron repletion, I think it's important to have a workup to make sure there's no other cause.
What lab tests should be done to accurately diagnose the cause of anemia?
Well, they mentioned, what we're worried about in somebody who has a low iron state is that whether there is iron loss. And, more commonly, iron loss occurs in the GI tract in a man. And occult iron loss could be a sign of colon cancer sometimes. So you want to make sure, a colonoscopy is done, there is no colon cancer. But I think, also sometimes going overboard and trying to look for, a capsule endoscopy and all of that is maybe not necessary, because a lot of the sources of iron loss are not found, and there could be AVMs. And so I think if a scope and age-appropriate cancer screening's been done, I think it'd be comfortable with those tests to replace.
Yeah, the full GI workup, is definitely a much more costly type of testing, much more uncomfortable for the patient too. And I think the yield is actually relatively low. So unless I see clear evidence of GI bleeding, right? If there's no clear evidence of GI bleeding, I'm happy with a colonoscopy alone. But if there's clear evidence of GI bleeding, then maybe that will, and the colonoscopy is negative, that would maybe push me to try and find other source for the bleeding. But beyond that, I don't think I will do anything else.
I think the only thing to add is when you have rheumatoid arthritis, you get an inflammatory reaction, and that can add some complexity to interpreting iron studies. But in fact, if the ferritin is low, then usually in an acute phase reaction, ferritin goes up. So this person really does look iron deficient, but we should also check if they're on any non-steroidals for their arthritis, because then they may have other causes of blood loss. But yeah, I think a general look for primary bowel problems is worth doing, but based on clinical assessment.
Norman is 76 years old. His chief complaints are shortness of breath and nosebleeds. His hemoglobin is 8.3. He has a history of congestive heart failure and valvular heart disease. Labs reveal a low platelet count of 88, high total protein, IgM of 8,000, and serum viscosity of 4.4. His bone marrow biopsies showed an infiltration of 90%. A CT scan showed increased spleen size and multiple small lymph nodes in the chest and abdomen. His local oncologist, who is unfamiliar with Waldenstrom's, asked for a consultation to determine the best treatment plan.
Yes, this guy needs internal medicine thinking. So we're all internal medicine doctors first, and then we're hematologists, oncologists after that. And so I look at him and I go, okay, this is a guy and from a medicine point of view who has heart disease and he's anemic, and that's not a good combination. Because if you're anemic, that means you have fewer red blood cells. Red blood cells deliver oxygen to our body, including the heart. And so this is a guy that we need to fix pretty quickly. This isn't a guy where we can think about it and ruminate about it. So that's number one. Number two is this is a textbook case of a CXCR4 mutated Waldenstrom's patient. And so with the high IgM, the heavy marrow involvement, et cetera, et cetera. And so this is a guy where I would think, okay, what's the best way to fix him and fix him quickly? And so I think I would be, this is where I think we may have some discussion here. I'd be thinking, even at 76, I'd be wondering about chemoimmunotherapy for this guy as my initial therapy. And the issue is when we use rituximab-based treatments with an IgM of 8,000, many of us are familiar with Rituxan flare. And so this is a guy where if he's viscous like this, I would also plasmapherese him, I think, early in his treatment course. And the local oncologists sometimes don't have the ready access to plasmapheresis that we probably all have up here. And so this is a guy where I'd be wanting to pounce on him pretty quickly and pretty aggressively.
I mean, I agree, actually. I think the nosebleed with this platelet count is usually, unless you're on anticoagulant, it kind of tells you maybe maybe there's a von Willebrand that's acquired, and that's maybe an indication to do the apheresis. And it gives you a little bit of time, buys time to look at the marrow, the genotype, confirm it, but and if possible to do something like BR or DRC, depending on how significant is his performance status from valvular and heart failure condition. But I agree. I think this patient looks like needs a treatment pretty soon.
So I think, yeah, I would plasma exchange and transfuse a little bit maybe, because he gets better oxygen delivery. He's very heavily infiltrated marrow, so I would also go with our chemo approach. I would defer the rituximab because I'd worry about flare, and if giving Bender, I would give a lower dose, maybe 70 milligrams per meter square instead of 90. I would be very cautious because he's got very little bone marrow reserve. I think if he's got concurrent iron deficiency, I would consider IV iron to boost things as well. So it would be done in a sort of sequence, but in a way, in a pretty semi-urgent way. But I'd also work up his heart, because if these things don't work and we're thinking maybe about BTKIs going forward, it'd be nice to know what his condition is in any case, and optimize the heart failure with maybe a cardiologist as well. But yeah, I think it's quite urgent. We need to have all hands on deck, but kind of come from different angles to cover all the bases as well.
Paul is a 60-year-old college professor who was diagnosed 2 years ago. His labs and symptoms suggest a need for treatment, but he's skeptical about the current options. He's spent considerable time researching WM and wonders if his DNA can be sequenced to determine the best drugs to use. He's already taking ivermectin and would like to continue it. He's already purchased an immunotherapy in an intramuscular injectable form and is about to start that and wants to give it a chance. Paul is also interested in using hyperbaric oxygen to starve the cancer. His local oncologist isn't receptive to alternative treatments, so he's seeking a second opinion to validate an alternative treatment plan.
Definitely one for the Dana-Farber, I think.
That sounds like it's
That's a Dana
Jorge question. It's all yours.
These
First of
questions
all,
come up a lot.
I think we should increase the dose of ivermectin.
Albendazole?
Exactly, whatever they need. Yeah, I mean, unfortunately, this is not totally out there. I mean, we have seen a few cases of patients who like to read about these alternative treatment options, and they feel that this is the best way to go for them. I think most of us here in the stage would agree that a lot of these recommendations are treatments that are not standard treatments for patients with Waldenstrom's. And when we think about standard options for patients with Waldenstrom's, are treatment options that we have designed clinical trials for, that we have developed protocols with all the safety nets permitted by us and by the FDA and our institutions. And that's the evidence that we tend to see, so we call the degree of evidence. So these other treatments like ivermectin and this immunotherapy, I don't know which type of immunotherapy is that is intramuscular, and hyperbaric oxygen, all those are options that are not standard. That means there's no clear research in patients with Waldenstrom that have shown to be beneficial. So I think our position, I mean, this is a college professor too, so we need to be acknowledging that there's some understanding from the patient's perspective. So I think it's a difficult situation, right? Because the patient's coming in with all these thoughts, and this is not matching what we think might be in the patient's best, interest. So I think what we can do in situations like this is we need to make sure that we provide a clear message, right, in terms of, based on what I'm reading, these are treatment options that you're using are not standard. These are our standards based on this, and we try to explain at least logically our approaches, and then at the end allow the patient to make a decision in terms of Do I continue with these alternative options, even though I'm not getting a validation the validation that I wanted from the second opinion physician, or I then the reason I went to see a doctor for a second opinion is to understand my disease better, and maybe the patient will think a little bit more about standard options in that situation, challenging situation.
I think this is where the art of medicine is really, really, really important, because I think you have to, on some level, establish some trust with this patient and validate their perspective, maybe not the treatment, but where they're coming from. Mm-hmm. And then I've faced this issue before, and sometimes what I've done, especially if there's no imperative to have to treat and fix the disease right away, I'll say, look, let's why don't we just, I'm okay with this, let's do it for a few months, let's make a deal here. If you're not better after a certain period of time here, then we probably really need to move you to more traditional treatments. Mm-hmm. And sometimes people will buy that and sometimes they won't. Mm-hmm.
The issue, I agree, that's a way to go. I don't think it's wrong. But the concern that I have is, it's not like ivermectin doesn't have any toxicity. It's not like hyperbaric toxicity doesn't have any toxicity. I have no idea what immunotherapy is. So I cannot tell the patient that, oh yeah, this is fine. Maybe you can say, you can continue with this. However, these are all the potential risks that you are running by continuing in a treatment that is potentially toxic and not clearly to be beneficial, right? So at least you can, make sure that you're providing, a message that hopefully the patient can understand.
I will add, it's kind of very hard for us to see this because, WM is a condition for which there is very good treatment. And, if there was a situation where, there was not a good treatment, and, perhaps I'd be a little more understanding and, but it's kind of particularly hard when there are very good treatment options and patients can do quite well, and to have, somebody who's kind of, dismissing, things that, a lot of advances in therapy that have occurred, it's hard on the physician's part of it. So that's all it's sometimes also a lot harder to convince the patient of the alternative before it's very late.
Some patients are really scared of chemotherapy. Do you have certain explanations to help them accept the inevitable, or?
Use different terminology. So, yeah, that's right.
Not chemotherapy?
Weed killer.
And I'm talking, yeah.
Let's call it ivermectin.
Yeah.
Targeted's a great word.
Okay.
Immune's a great word.
Okay.
And I think sometimes you even just have to explain that different chemotherapies are different, because sometimes I have patients, they say, my mother had ovarian cancer and I saw her suffer from chemotherapy, and I think it's helpful to give a little bit more information in that setting about the difference between using bendamustine and maybe a chemotherapy for a different condition. A lot of patients, rightly so, worry about hair loss, and when you think about bendamustine compared to maybe a chemotherapy for ovarian cancer, even that small thing can make a big difference. So I think giving a little bit more information in that setting might help put their fear into context and help us to be able to explain if there are other ways of thinking about it.
Sometimes I put the patient in touch with someone else who's been through that treatment, obviously getting their permission, and then they can have a conversation between themselves as to how it was and perhaps allay some of those fears. So that's another way I think that's helpful.
And what I tell my patients usually is, there is chemotherapy, that's an option, but there are many other options that are not chemotherapy as well. So even if one of my patients were not to feel comfortable after I discussed the fact that there are more gentle chemotherapies, the toxicities are much less pronounced than before, and despite the fact that they are more gentle, side effect-wise, still very effective, we still have a lot of other non-chemo treatments that we could potentially discuss, right? And what I tell my patients sometimes is, well, you're not choosing really to use chemo or not, you're choosing what to use first, right? Because if treatments don't last forever, maybe a treatment in the future, there's always the option that you might need this in the future, right? So I think it's just about the perspective much more than the word, that sometimes some patients are afraid of.
Trudy, a 72-year-old retired librarian, was diagnosed with WM 3 years ago. She is currently experiencing significant headaches, severe lower back pain, cognition difficulties, gait and balance problems, tingling in her hands, and excessive daytime sleepiness. Her local oncologist said labs and symptoms do not warrant treatment and has dismissed her suggestion that she might have Bing-Neal syndrome. So she's seeking an oncologist who will do the appropriate testing. Dr. Desai?
So I think these symptoms, the first thing I thought of was Bing-Neal, because I think it's something that one should exclude, but not with a sort of, not without thinking of other possibilities. The thing that makes me think about it is obviously the underlying diagnosis of WM, the fact that she has significant headaches, lower back pain could be due to nerve root infiltration, cognitive difficulties, and all, you know, this could add up to a diagnosis of Bing-Neal. So I wouldn't hesitate to actually do imaging on this lady with an MRI scan. As Shayna had said in her talk, it's important to do an MRI before you do any lumbar puncture, but depending on what that shows, because we can't dismiss the possibility that there may be something else other than WM causing problem. I would fully scan the head, the brain, and the spine with contrast, and if there are features that confirm, or even otherwise, I would probably proceed to a lumbar puncture. And if it confirms Bing-Neal, then I would restage her, or I would, well, she had it 3 years ago, so I'd check her marrow and see where we are with the WM and consider treatment. If it's not Bing-Neal, then I would refer her to she would need some further investigations to figure out what it actually is.
I agree. So surgeons always say if you don't remove a lot of normal appendices, then you're not doing enough appendix operations. And for me, if I'm not looking for Bing-Neal and having a negative workup, I'm not looking hard enough for Bing-Neal, because Bing-Neal is always that thing in the back of my mind that I worry about, and I have a low threshold for evaluating a patient for Bing-Neal, because it's just something that none of us want to miss. And I would say that if you went to the average hematologist oncologist and said, I think I have Bing-Neal syndrome, they would have absolutely no idea what you were talking about.
Yeah, no, I agree. I mean, obviously, we don't have any numbers here, right? So significant headaches and cognition difficulties, I mean, could be hyperviscosity as well, right? So that could be part of the differential diagnosis. So I will make sure I understand very well, you know, the patient's blood counts, the patient metabolic panel, the IgM levels, right? Make sure that we are not thinking that this could be something else. But yeah, Bing-Neal syndrome, once we have a concern, I think, you know, MRIs, lumbar puncture, and sending the spinal fluid for specific tests like flow cytometry, and in some centers can actually do the MYD88 testing in the spinal fluid, and some other genomic testing as well. We typically prefer to run these tests in parallel with tests from the marrow taken at the same time, so we can maybe match some of the molecular testing. There's something called an IGH, you know, gene rearrangement that we can match sometimes the spinal fluid with the marrow to make sure that we're talking about the same type of cell. So there's a lot of different tests that we can do to really get into a good diagnosis of Bing-Neal syndrome. Now, something that I wanted to bring up too is, for example, some patients get this type of testing for headaches. Once the testing is complete, the headaches actually resolve, the patient feels well, and the patient has a diagnosis of Bing-Neal syndrome, who is otherwise asymptomatic. You know, it's rare, much more rare. But in that situation, we treat the Bing-Neal syndrome like Waldenstrom. So if you are asymptomatic, even though you have a diagnosis of Bing-Neal syndrome, more likely than not, you will be observed rather than treated if you have no symptoms from it, you know, which is a rare situation, but we have seen ourselves in situations like this in the past.
It seems like we're seeing a lot of Bing-Neal syndrome. Is it still considered rare?
I don't know, it's a lot. But yeah, so I think at least I can speak from the Dana-Farber experience. When we had our first paper out, 2016, I think it was about a 1%, 1.3%. And the most recent evaluation that we did were about into 1.8, you know, approaching the 2%. And I don't know if it's because big needle syndrome is increasing or because we're checking it more often, right? Patients are more aware of that, and then that prompts more testing, or maybe just the fact that patients are living longer with the disease. And so I think there's a number of different potential factors that play into that.
I think it's probably more common than has been billed so far.
Belinda, a 54-year-old teacher, was diagnosed with WM in January of 2020 and received 4 rounds of bendamustine and rituximab. She had a very good partial response and has been on active surveillance since then. Recently, her IgM, other labs, and symptoms indicate disease progression, and her local oncologist wants to begin treatment soon with a BTK inhibitor. She's nervous about the side effects and not sure if she wants to subject her body to this for the rest of her life. She's wondering about other treatment options and if it would be appropriate to repeat B&R.
Luckily, there are other treatment options she could consider if ultimately she doesn't want to stay on a BTK inhibitor indefinitely. But I think, again, as we were saying with chemotherapy before, I think it's important to talk with the patient about what they're nervous about and what they've heard in terms of side effects, and see if maybe a little bit more conversation might help tease out what the patient is nervous about. Because maybe a BTK inhibitor is a good option, but if the patient really does not want to stay on therapy indefinitely, other things that you could consider. So sometimes in our younger patients, we don't use this regimen as commonly, but there is a regimen with bortezomib and rituximab. We tend to use it in our younger patients more often, and that's another regimen that could be used, and we use it for a finite amount of time, usually about 6 months. So that's something to consider. I would say other things that we often use, usually after a BTK inhibitor, but venetoclax is another option we have in the relapse setting, which we often use for 2 years and then stop. Clinical trials are always an excellent thing to consider in this setting, because maybe there are options like the pirtobrutinib venetoclax trial, where again you have a limited time on treatment. I would say it's my personal preference generally not to go back to bendamustine because of the risk to toxicity to the healthy cells in the bone marrow, and repeating that again would increase that risk substantially. So I typically don't go back to bendamustine. Once in a while, I think we consider it, but that's usually if a patient's had a much longer time of remission that we might repeat the same therapy. So sometimes we have patients that were on one therapy even 15 years ago, and they had a very long remission, and sometimes we'll repeat therapies, for that's, a very long period of time, but sometimes I think 4 or 5 years is not the time frame that I would feel comfortable even repeating most therapies, but especially not bendamustine because of the risk to the healthy bone marrow cells.
Would rituximab maintenance have been an appropriate follow-up to her BNR infusions in 2020?
Okay, I'll go. So yeah, rituximab maintenance, I use sometimes. Certainly if somebody has BR is in VGPR, I probably would not. But you can increase the time period where the disease doesn't come back, but ultimately it's not clear that you're improving survival. There is a risk with rituximab maintenance for an increased period of time where the patient's more susceptible for infection. After the pandemic, we're definitely more aware of this and cognizant of this. And but going back to the main question related to 5 years, from benefit from BR, it sounds like a long time, 5 years, but in our world, not particularly. So again, I would hesitate to reuse BR in this case. And I'll try exactly what you're doing. Sometimes you can look for some of those myeloid mutation in the blood to see if this is a patient who maybe has a CHIP mutation, where you're going to try to stay away from retreatment with alkylators in patients who've had a longer period of benefit, for example, where you would reconsider retreatment with alkylators.
There's a paper that most of us are waiting for. We may not see it published in our respective lifetimes by Dr. Rummel, where he looked at patients with different lymphomas, including Waldenstrom's, that were treated with this combination of bendamustine and rituximab. And then they did a coin flip after the chemo's finished to either no maintenance or maintenance therapy. And long story short, there was no obvious benefit to maintenance therapy for the entire group. And so when I saw that paper presented, I used to do some rituximab maintenance, but I've largely abandoned it, except for if somebody's got some residual disease I don't like, or something autoimmune going on, or some other reason to think about it, but I've largely abandoned rituximab maintenance. Yeah,
That's going to be a very difficult situation because my understanding is that paper is not going to be published
In our lifetime.
in our lifetime, and that is an issue. So that is a problem. Why? Because the study, the maintained study, it was just purely on Waldenstrom's. There were actually 200 patients who got at least a partial response. That means an IgM decrease of 50% or more. So it applies to those patients specifically. Now, if you look at the time, the average time is longer in the people who got the maintenance than the patients who didn't. But statistically speaking, there were no differences between the two. So the problem is, if the paper is not going to be published, the paper has been presented at different meetings, conferences, and all that, so we're aware of those data. But if it's never going to be published, should it change management if it really has not been formally peer reviewed and published? And that's the part that we always argue about or discuss about during our meetings when we decide, or at least trying to talk about patients and how to approach those patients. So yeah, I myself have decreased the number of patients that I recommend maintenance on, specifically after chemo or chemo treatments, rituximab-containing treatments. Somebody got a 50% decrease on the IgM. Almost nobody gets maintenance unless somebody with neuropathy who want to deepen the response, somebody who has kidney disease, which is very rare, want to protect that kidney. So there are some specific situations in which I could potentially recommend some maintenance, but really the percentage of patients that I recommend maintenance now is much, much lower based on that study.
I've seen too many patients with very deep hypogammaglobulinemia to, even with BR, without maintenance. So I'm really quite allergic to maintenance. I guess one exception is amyloid, if someone has, and you're really after a deep response, but other than that, I would never really use it.
So is it falling out of favor? I think maintenance is falling out of favor at this time.
Robert is a 78-year-old retired farmer who was diagnosed 22 years ago. Past treatments include rituximab, DRC, and bortezomib. He's currently taking zanubrutinib and showing signs of disease progression. He says he feels like throwing in the towel and stopping treatment, but his children have convinced him to get a second opinion. I have a couple follow-up questions. How do you evaluate the frailty and ability to tolerate treatments? Are some treatments easier to tolerate for the frail elderly?
So first, in regards to this gentleman, I think there are a couple of other options that he hasn't had, and particularly like pirtobrutinib. I think I've transitioned some people from zanubrutinib to pirtobrutinib, and if they're tolerating zanubrutinib well, they tolerate pirtobrutinib just as well, in my experience. And so that might just be an easy transition that's not going to add significant toxicity or any toxicity particularly for him. So that could be something that he could consider, especially if his fear is about what the next treatment might bring in terms of toxicity. He could also consider venetoclax as well as another therapy. I think so. I do think there are other things he could try that maybe might be pretty simple and allow him to still be at home and spend a lot of time with his family or whatever his goals are. I would say that frailty, I think, is something. Maybe I'll let Dr. Desai talk more about this, but I think it's a little difficult to assess, and it's really on an individual basis with each patient. I always try to get an idea from the patient about, what they're able to do, what they would like to do, and problems that they have otherwise in terms of their medical history, to try to get an idea of what they might tolerate in regards to therapy.
Yeah, I'd agree with that. I think we need to take get an assessment of his general health, but also explore why he's not keen to continue treatment, because did he have particular side effects that he's not keen on, the fact, is that what's influencing him? Is there a degree of depression, which obviously could be the case because he's getting progression of his disease. But I think there are the other options like the sonrotoclax trial, for example, as well. So I think a sort of examination of his fears specifically. I think as a physician, I'd be very keen for him to continue because he's there are still other lines of therapy available. But at the end of the day, if he really, really feels that way, then one could continue him on, if there's signs of disease progression, it could just be an IgM going up. He may be actually okay, so we could continue it and just see how he goes over the next few months, and then reassess maybe in a few months, see what he thinks.
I think it will be important to develop a formal, frailty assessment for patients with Waldenstrom's. I mean, nowadays with the newer treatments, like BTK inhibitors, and I think it's a little less important, right? If the patient is frail or not, I think they can tolerate easily, with the data that came out, from Shayna, with the dose reductions and how to manage the side effects in these patients. So I think, the whole frailty situation was a concept that was developed in myeloma and CLL when you had like transplant patients, you have to transplant patients, give them, high dose chemotherapies. And I think, with the newer treatments that are less intensive and probably a bit less toxic, I think, maybe playing just a little bit less of a role in terms of the making decisions. And unless the patient is truly, in a bad shape, right? I think that's a little bit different.
Yeah, and I'm only add about the frailty. There's frailty systems that have been developed for lymphoma patients. All mostly have been validated in patients receiving, chemotherapy. And so not much with, say, BTK inhibitor, BCL2 inhibitor. And it's likely that, it could be different, the impact of frailty on the tolerability of those agents. We're fortunate we have a strong geriatric oncology program, but we could do a formal geriatric assessment. I think that could be very helpful in trying to figure out, whether there is true, frailty but then, you can always unmask elements of depression and, the cognitive changes that, we can see sometimes, as well that are more prevalent when we age. But I think that is an important part of assessing an older adult.
Olivia is the 28-year-old mother of 3 young children who has been anemic for several years, with many other chronically abnormal blood counts. Her father has multiple myeloma. She was recently hospitalized for a urinary tract infection, during which she insisted on further testing, and her IgM was 2860. The physical examination revealed 3 enlarged lymph nodes. She suspected she had Waldenstrom's until immunofixation tests showed no M spike. Her oncologist has dismissed her concerns, and she's seeking an oncologist who will do a bone marrow biopsy. Follow-up question is it possible to diagnose WM with a lymph node or other tissue biopsy?
Okay, I think, first of all, that age is really young, so it makes WM less likely, but probably not impossible. I think these days, anything is potentially possible. She has chronically abnormal blood counts. I'd like to know a bit more. Young women who've had kids can often be anemic because of just chronic iron deficiency, pregnancies, etc. But she's got a family history of a plasma cell disorder in her dad. That could be a coincidence rather than relevant, but probably has influenced her thinking, probably been quite traumatic for her. The fact that she's had a urinary tract infection is suggestive of, well, it's either that just one of those things, because people can get UTIs, but maybe it could signify a slight tendency. The IgM, I think is that 27 in my money? Yeah. It is pretty significant, but it is not based on immunofixation. It's not clonal. I would wonder about some sort of chronic inflammatory infection-related thing that is sort of just simmering in the background. I would not be rushing to do a bone marrow, but if she, given her history, and I mean, I wouldn't deny her it, actually, but then in the UK we do them for free, so we wouldn't charge her for it, we'd just do it anyway. But I would like really take on board her concerns, and if she really felt a marrow was something she needed to exclude, I would say I'm accepting, but it partly would be curiosity as to why she's got this.
What about the lymph nodes? I'd be very curious about the lymph node.
Yeah, you could do a
It's how big they
core
are.
biopsy.
It says enlarged, but I don't know
Marginal
what,
zone,
sometimes you
how-
don't know what that means,
how
right? The
enlarged?
ultrasound
Be
says
reacting.
enlarged ultrasounds and enlarged lymph
Yeah.
nodes, and they're all like 1.2 centimeters. And I'm like,
Could do a core
that's
biopsy.
not enlarged enough.
This is somebody that will make us really, really nervous. You're going to follow this patient very carefully to see what happens at IgM. Is it reactive? Make sure it's not clonal. Repeat your test, and watch those lymph nodes. And I think with these weird complaints, I'd have a lower threshold for biopsying a lymph node before I went and did a marrow, unless her CBC was really perturbed. But I want to know more about those lymph nodes.
I agree. I think the patient is more in the age range where you would think about rheumatologic or autoimmune issues maybe causing an inflammatory state. But I also agree with Dr. Desad that if this patient is going to have sleepless nights, not just because of her children, but because of anxiety for the next 20 years, then it's probably worthwhile to rule that out, doing a bone marrow biopsy. But since there's not a clone of the IgM, it might just be her immune system has some inflammatory response from another condition or her recent infection.
Yeah, I think we have seen a few patients like this in the clinic, right? And then the conversation always goes, well, you know, it's very likely that you do not have a malignancy, right? And I think the bone marrow biopsy will be of very little help to you unless you really want to have it done. And the patient, some patients says like, yeah, I would like to have it done. That's why I'm here. And some patients will be like, you know, I think we can continue watching and see how you do. So I think I will put it out to the patient, understand the risks, pros and cons of each process. I would say most patients probably would have a bone marrow biopsy. Most patients in this situation, you know, with this kind of vibe, you know, probably they would like a bone marrow biopsy to confirmation. I don't think we can deny that to them.
Terry is a 65-year-old plumber who was diagnosed with WM in 2014 and has been on active surveillance. 6 months ago, he developed back pain in his thoracic spine. He got some pain relief with an epidural, but within weeks, he began to experience urinary incontinence and severe postural bilateral sciatica. A repeat MRI showed a spinal tumor, and a biopsy revealed lymphoplasmacytic cells. He's been advised that radiation is the best option, followed by zanubrutinib. He's seeking a second opinion to confirm that is the best course of action.
So soft tissue and not bone, presumably? Is that what everyone's thinking with this, like a paraspinous?
Most
thing?
likely, yeah.
Yeah. Yeah, so like almost like a big Neil. Yeah.
Kind of.
What
I like
is-
that.
What is the incidence of extramedullary WM? Do you see it a lot?
Yeah, I don't think we have a very good definition of extramedullary disease to begin with, and that makes it challenging because, you know, about 30% of patients will have lymph node enlargement, and that could be considered extramedullary disease because it's outside of the bone marrow.
Okay.
Or you can have 20% of people with large spleens, and that could be also considered extramedullary disease.
Okay.
So if we have all of them, right, I think probably 40% of people will have extramedullary disease. But if you want to remove the more common extramedullary diseases and leave alone just big Neal syndrome or bone lesions or kidney problems or pleural effusions, I think that percentage will be much, much lower. So I think it all depends what the definition of extramedullary disease is, and I don't think we have a good one at the time. Would you guys agree with that? Yeah.
I was going to say, when it's a spinal tumor, I'd obviously want to know what, is it in the spinal cord or is it around the cord or whatever?
Intradural penetration.
And probably get the biopsy like analyzed for genetics, looking for slightly weird and wonderful things, aggressive potential. But I think acutely, if he seems to have signs of compression of his neurological functions, then I think it's very reasonable to irradiate the tumor alongside a full like PET scan to check disease elsewhere, marrow. As for following up with zanubrutinib, I think it would depend on what else is affected and to what extent. Not necessarily would be my answer.
I would agree. I've definitely seen a handful of cases, just a few, where the biopsy is lymphoplasmacytic lymphoma, but then we don't see signs of disease elsewhere. So the bone marrow is negative, and a full body scan doesn't show any other signs of disease. And in those cases, I've treated with radiation to that area, and then have been able to follow the patient for years with no other signs of disease progression. If the patient has a bone marrow and they have Waldenstroms and they have anemia and there's another reason for zanubrutinib, I think treating with radiation first and following with zanubrutinib is reasonable. But if there are no other sites of disease, then it might not be necessary.
I think we have some time, a little time for questions.
So we get a lot of people are nervous to treat, right? So they find that they have it, and kind of going back to that, alternative methods. I always have this question again in my mind: what happens if you don't treat? Like you just go, well, I'm scared, or I'm going to try X, Y, and Z, but what happens if you just say no? What's the progression?
So it will depend on the patient. Some patients have, disease that kind of gets worse very fast, and others where it does, very slowly. And I've had a patient who refused treatment 5 years ago, and obviously his disease deteriorated. But he's still around 5 years later without treatment, although very anemic, transfusion dependence, which is not a good quality of life. On the other hand, some patients could have deteriorated a lot faster sometimes. So it's the pace of change could vary, but generally speaking, the indication to start treatment is there is a start of symptoms, and the goal of treatment is to make the patient feel better too. So. When you approach it this way, a lot of patients say, well, actually, I do want to feel better. So the point is that the treatment is not punishment. It's not, meant to do that. It's meant to make you feel better.
We don't, because they have me. Sorry.
On that same note, I think it's important, at least from the way I look at this is there are other conditions like aggressive lymphomas and myeloma and leukemias in which you make the diagnosis, you need to treat immediately, right? Because there's a benefit. Either the patient, you can make them live longer with treatments and things of that nature. In Waldenstrom's, it's essentially a quality of life issue. And therefore, it's not like you cross a line in which treatment is totally indicated. It's more, you enter an area in which treatment is reasonable, and some patients would like to be treated with less symptoms, and some patients would like to wait a bit longer and be treated with more symptoms. So I think it's a conversation that needs to happen between the clinician and the patient, because obviously some patients would like to delay treatments, but for example, they could be, we could be allowing for the kidney dysfunction to progress and maybe become irreversible. In that situation, our position will be very different than if somebody will be slowly becoming anemic, for example. So I think it really depends of the pace of the disease, so I agree with that, but also what is the problem, that is driving the issue. And if there's any irreversibility to whatever is happening, nerve damage, kidney damage, or what have you, I think that's something we need to talk to the patients about as well.
All right. Maybe because I'm an old guy, but for those two people that were 74, 73, one was a veteran and one was a farmer. Both could have chemical exposures as well. The veteran would have been Vietnam-era veteran. So that crossed my mind. And the other thing, because many of us are involved with support groups, for those people who come in and they're questioning treatment, maybe let them know that there's support groups out there, because people in the support groups could share information about the various treatments that they've had and what their success has been, and it might take some of the pressure off the physician to have to, kind of convince them that this is the reality of it.
Well, these are very good points. We have maybe more privacy issue in the US, so matching them with a patient who's been through it is hard. But on the other hand, you have exposure to this a lot of time in a support group, and I think that could be very valuable.
I think it's valuable up to some degree because everybody's journey is different, right? So what one person experienced with one treatment might not be what other patient experienced with the same treatments, and that makes just a bit more challenging sometimes to provide, kind of a one-size-fits-all type of approach. So that will be, the counter to that. I think there's benefits overall, just as a sense of community in understanding what other people might be going through, but also understanding that not everybody will experience the same thing with the same treatment.
Absolutely.
Thank you, doctors. We really learned a lot.